Morning, everyone. I'm Wendy Frankel. I'm the chair of pathology at Ohio State University, and I welcome you all to this beautiful venue, a beautiful sunny day. And what we're going to talk about today is medical liver. So we're going to try to keep it really practical. That's really all I can do, and that's the way I teach and the way I practice pathology. And we're going to start off with a series of 9 cases. The first few will look kind of similar, and they'll start a little simpler, and as we build, they'll get more difficult. And I know you've all had a chance to look at the cases. So what I want to do is talk not just about looking at the slides, but I think medical liver is an area that many people aren't comfortable with. So what I want to do is talk a little bit about the approach too. So as we look at our cases, think about what's your approach and what's you're going to sign out be like. So what are you going to say? What's going to be on the line and what's going to be on the comments, right? So, and what we'll try to get through is the approach, kind of starting on low power, coming up with what's the overall pattern, and then from there come up with the differential. So we're going to be focusing on where's the action? Is it lobular or portal? And then what is it? So where is it and what is it? We'll get our differential. We'll come up with what we're thinking about. You may have more questions. I may know more I could tell you about the patients. And then we'll come up with the best diagnosis we can. If we have to be descriptive, we will be. If we could be more specific, that's even better. And part of this is going to depend on how much clinical information you have. So let's start. Case 1. Case 1 is a 38-year-old obese woman who presented with jaundice and elevated LFTs, and that's usually what you get, right? But if you get more, her AST was in the 2000s, her total DILI was 14, viral serologies are negative, and she denied any alcohol or drug use. So, as we look at this case, and again, starting with our approach, starting on a very low power, and we scan around, what's everybody seeing? And let me go one more power and let everybody focus a little bit. But what's everybody thinking? What's the overall thought? Where is the action in this liver? Lobular. So it's all over the place. And when I look at a case where it's kind of all over the place, it's in the lobule, it's in the central areas, and the portal areas too, but you could see it's not, and hopefully everyone can see this arrow, the portal area is not the main area of the action, but it is involved here. So it's all over the place, and let's now go down and kind of think about what we're seeing. So there's inflammation in the liver cells, in the sinusoids, portal areas. Anyone have any ideas about the types of inflammatory cells? Anything in particular that you're noticing, or are they just kind of general? Yeah, so some plasma cells, some lymphocytes, so that is important to pay attention to. Some dead hepatocytes right above the arrow, right? So single dead hepatocytes, there's ballooning degeneration, but the key thing... Some eosinophils. Yep, eosinophils scattered about, good thought. Another dead hepatocyte. The bile duct looks okay, so we're not thinking of biliary etiology, so kind of mixed inflammation. But there are some plasma cells in EOs, and maybe some cells right above the arrow, right where the arrow is, filled with some pigment maybe, so maybe some resolving a little bit. What do you think would happen if you did a Ki-67 in this case? Pet peeve for me. I get cases sent in sometimes like this, and they've done a Ki-67, and it's really high. It's like 90%, and they're worried about tumor. So I think this pattern, and the pattern that it sounds like everyone's saying we're looking at with lobular disarray, is an acute hepatitis. So with this pattern, you get a lot of proliferation. You get a lot of mitotic figures. You get a lot of regenerative cells. And so number one, I would never do a Ki-67 on a medical liver case. But if I did, I wouldn't worry about that and start to worry about a tumor. Okay, so now, what else do you want to ask this patient, or what else do you want to know? So denies alcohol medications, has elevated LFTs. Do you want to see any other stains? Connective. Yeah, so someone said connective tissue. I would want to see a trichrome, because the trichrome is going to help me with, is this an acute or a chronic process? So we've got our trichrome, and I think the trichrome is good and bad. It's good, it's overall a good stain when it's nice dark blue, but when it's this wimpy light blue, so is all this fibrosis? I mean, look at your control on this slide. That's what we're looking for, that for fibrosis. So what we're seeing on this is this kind of pale blue, could be edema, could be necrosis, but it's not fibrosis. How do I find some real, like maybe this portal area, that's probably some real fibrosis, right? So that probably is. But for the most part, there's no fibrosis. So this is an acute hepatitis, right? Characterized by lobular disarray with a lot of regeneration and degeneration. Really no clues to me. Some of you guys mentioned plasma cells, so maybe think about autoimmune, but other things can do that, right? Some of you mentioned EOs. EOs can be seen in a lot of things. They do make you think about drug, but they can be seen in a lot of things. So this is an acute hepatitis. So what's our differential here?
Infection to the autoimmune Wilson.
Right. So differential, and for those of you who didn't hear, I'm just going back to the primary case again, is viral, so acute viral hepatitis. Acute autoimmune hepatitis, remember, even though autoimmune hepatitis tends to be acute on chronic disorder, it can also be fulminant in some cases. Wilson's is always in your differential if you're thinking under 40-ish-year-old, and drugs. So I'm going to tell you more about this patient. So even though this patient denied drugs and alcohol, then she was asked about supplements. And that's so key these days, right? This woman, we found out, who was obese and always trying to lose weight, was a Herbalife salesperson. And she took Herbalife as a tea, and she took it like for 3 weeks. And then she developed these symptoms. And when she stopped the Herbalife, she got better. So this is thought to be acute hepatitis. It's a DILI, a drug-induced liver injury, likely due to Herbalife. And so you would sign this out. What you put on the line is acute hepatitis, no fibrosis, C note, and in your note you would give a differential, and given the history, it's consistent with a DILI from Herbalife. And I'd say something like that. The key thing is the fibrosis. And since you do know enough to say that's likely the diagnosis, I would absolutely include that. So I just want to show you a couple other similar cases. This next one is a kid, and so you guys didn't look at these cases, but just to get the feel for how similar these cases can look and how few clues we actually get for this. Sorry about the wrinkles in this slide, but it's a good example. This is a 13-year-old who had just undergone a surgical procedure, and this was years ago, and this is halothane, hepatotoxicity. So again, when you look at this liver, you're thinking messy. Everything is all over the place. It's not portal and periportal. It's not a fatty pattern. It's not a cholestatic pattern. This is just a mess, and it's even sometimes hard to see that this is liver. So another good example of acute hepatitis and another drug-induced acute hepatitis. So really important when you're looking at the drug history, it's not just current drug history. DILI can occur months and months after. Anybody know most common cause of DILI? So first of all, DILI is one of the most common causes of acute liver failure in the US. And about 50% or more than 50% of DILI is due to acetaminophen, right? So that's huge. And different drugs can show different patterns. So what I want everyone to do as we go through these cases, think about the different, think for every pattern about a drug and keep that in the back of your mind, and we'll look at some more too. But this is another acute hepatitis. So again, that should be what everybody thinks when they look at this case. This is absolutely acute hepatitis. Where's the action? It's everywhere. And what is it? It's kind of mixed inflammation. It's in the sinusoids. It's in the portal areas, right? There's interface activity a little bit, but that's not the primary pattern. There is portal inflammation, but it's everywhere. And there's dead hepatocytes and again, mitotic hepatocytes. So kind of take home for acute hepatitis pattern is your differential that you guys all mentioned, autoimmune, chronic or viral, Wilson's, drug. Those are your main things in your differential for these cases. And what stains, I would say the trichrome is your main stain, right? You could do a copper for Wilson's, but it's not going to rule it out. Once in a while, I'll use an Orsian if I'm struggling with if it's fibrosis or not, when I see that wimpy trichrome. But other than that, that's all I do. No other stains are going to help you here. I would not do Ki-67. It will only confuse you. Okay, case 2 is a 15-year-old girl with a 1 week of right upper quadrant pain, jaundice, pruritus, dark urine, vomiting, and diarrhea. Her tox screen shows morphine and THC. She admitted to using alcohol and cannabis, and she's got ALT and AST around 1,000, ALK Phos a little high, total Billy 10, and her ANA is 320. So, and as you look at this case, what's the pattern here? Same, right. So acute hepatitis, although this one has a little bit more activity in the portal area, but as you look around, everybody's focused all right? As you look around, it's in the sinusoids, there's some Kupffer cell hyperplasia, and there's dead hepatocytes, a little bit of fat, but that's not the main feature here. So another case of acute hepatitis, you start to look at the inflammation. Does it help you? Kind of mixed. I see a few EOs, maybe a few plasma cells. So what's everybody's differential? Same. So, and as you look at this now, but you were given the ANA. So she's got an ANA of, I don't know, 1, 2, 320. So this is autoimmune, and like I said, autoimmune typically is an acute on chronic, but this one was a pure fulminant. And as you look at this trichrome, and the trichrome may help you, and you've got the capsule here. So that's kind of your clue for what a nice dark trichrome, that would be fibrosis. And again, this is all much wimpier. So I think none of this is true fibrosis when you see this. So be careful of that. I've seen a lot of these cases where people have jumped to cirrhosis. So this again is acute hepatitis with no fibrosis, consistent with, and you could say consistent with autoimmune if you know a lot of the history and a lot of the labs. Otherwise, I would just put it in your differential. Everybody should know that autoimmune hepatitis is a diagnosis where there's lots of different things that are looked at when that diagnosis is made, and it's not just what we're looking at. It includes sex and the autoantibodies and lots of other clinical factors. So the key thing in your diagnosis is to call it acute hepatitis and then give a differential. So now what I want to do is look at maybe 3 or 4 other cases of acute hepatitis that you guys didn't see, but just to kind of look at quickly. And this one is a 35-year-old, and this is another autoimmune. And so what I want everyone, and this is a little paler, but what I want everyone to get a good feel for is that autoimmune hepatitis does not have to have primarily plasma cells. It can, and if it does, that's very helpful. But so, same pattern, and all these cases, you might think they look identical. And really, there's nothing here that would help you tell one from another, right? So I think, again, key, this is autoimmune. Now I want to show you one autoimmune that you probably would have picked up on.
Do you make comments on that many eosinophils?
Say that again?
Do you make comments when you have that many eosinophils in acute
I mention it because it may make you think about drugs, but I wouldn't. I would just mention it. I usually just say mixed inflammatory infiltrate, including. And I think your description is important, but remember, this is going to be put together with the history. So at this point, everyone's got this acute hepatitis pattern down, and lots of dead cells. You can sometimes, when it's resolving, see more of this kind of pigment scattered about and aggregates of it. Now, this one was an autoimmune that has more plasma cells. And although you could see plasma cells and stuff like viral hep A, when you see this many, I would absolutely mention it. I would ask for the labs, and pay attention to those.
Dr. Frankel, what percentage do you see as a portal-based versus a lobular? In other words, acute versus more of a chronic picture?
Well, more of an acute, I think it's more of, I'm going to turn the light up just a little bit. I think it looks really pale. Is it too bright for anyone? So, so see all these plasma cells? So there's not really a percentage. It's more of that lobular disarray that you're looking at. Usually in acute hepatitis, there's just as much in the lobule as a portal, whereas in the chronic hepatitis pattern, and we'll look at some of those in a minute, in the chronic hepatitis pattern, that's going to be where your action primarily is. You'll see a lot of interface, so right at that border activity. So if you have severe activity in a chronic hepatitis, you'll get more spilling into the lobule, but it'll be heavier in the portal areas. So before we move on to the next case and kind of the next pattern, just to make sure everybody is good with acute hepatitis, and I guess I want to make one last point. This is in acute Hep B. Anybody know, is there going to be any clues in acute Hep B?
Ground glass bones.
And I was trying to get people to say that, thank you. So ground glass you see in chronic. So chronic Hep B, you'll see ground glass, not in acute. But will you see anything specific for this versus anything else? Not really. See, this does have a little bit more portal, but the overall pattern is not portal with periportal. The overall pattern is this lobular pattern, this lobular mess, disarray, things going on all over the place. So again, the ground glass, look for in chronic, not here. Okay, so now I want to go to case 3, and as I said, as we move, the cases will get a little more complicated and more than one thing may be going on at once. So I want to get the basics down before we get there. Case 3 is a 35-year-old man who presented with anorexia and malaise. He denied alcohol or drugs. His ALT and AST were normal, but they've previously been elevated, and his total DILI was 1.6. So this is going to look a little different than the last group of cases, but where is the action primarily? So it's primarily portal with a little periportal, and some new things are showing up here that we haven't seen before, so we'll just mention them. Some glycogenated nuclei, right? You could see glycogenated nuclei in patients with diabetes, most commonly. So right above that arrow, a few others. Other than that, some other things we're seeing that are a little new. There's a little bit of fat in this case, but that's not the primary pattern, as you could see. Kind of minimal steatosis, so that's part of what you're going to mention in your diagnosis, but not the primary thing. So the primary thing going on here is a portal and periportal pattern of inflammation. It looks like there's probably some fibrosis, and we'll look at that with the trichrome later. Inflammation, kind of mixed, but mainly lymphocytes. Now there's something else showing up here. Yeah. So you guys who had a chance to look at this probably noticed this a little better. So you see all these cells right beneath my arrow, that kind of very homogeneous pink cytoplasm. Sometimes there's a halo, but yeah, ground glass, and this is a pretty good area where there's a lot. So this is a chronic hepatitis pattern, so everyone is thinking what? Hep B. But what else can give you ground glass? Because not just Hep B, not entirely specific. So yes, some cyanamide poisoning, some storage disorders, Laphoras, anything that revs up cytochrome P450, polypharmacy. I've seen this in patients who are on multiple drugs, kind of pseudo ground glass. So beware of that. But yeah, so you've got a clue here. You've got a chronic hepatitis pattern, right? So different or similar differential, but a little different. So your differential is now going to be viral and autoimmune again, but chronic. right? And then you're also going to be thinking about even like alpha-1 antitrypsin could give you this type of pattern. Some non-specific stuff like adjacent to a tumor can sometimes even cause this look. But the main thing I'm thinking about here is autoimmune and viral. And this case, as you look at it, there's not much action at the interface, so the arrow's right at the interface, right? So viral tends to be a little less active typically than autoimmune, which tends to show more severe activity, tends to show more plasma cells. Viral tends to show more lymphocytes, so that may help you somewhat. In this case, you obviously have that ground glass clue. Okay, let's look at the trichrome and then talk a minute about staging and grading. So the trichrome now is showing that there is some pretty significant fibrosis here, even on lower power. So pretty significant fibrosis. It's at least portal and periportal, and I think there's even some bridging. And this looks like pretty good fibrosis. And the other thing the trichrome does give you a clue to, did anybody notice? Sometimes those ground glass inclusions really light up with the trichrome. They kind of get pale blue. And so if you missed it on the H&E, you may see it on the trichrome. See it? Right above the arrow, there's a couple cells with that pale blue. So that can be helpful. If you miss it initially, you may see it on the trichrome. Turn up the light a little. But everyone saw it on the H&E, so that's great. So now, how are we going to sign this case out? So chronic hepatitis, right, with mild activity. I like Batts and Ludwig. It's really simple, right, 1 through 4. So portal, periportal, right? And if for the grading, it's minimal, mild, right? And moderate, severe. I usually don't go to severe unless there's some necrosis. So this is probably, so there's a little bit of portal with periportal. I probably would have graded this a 2. So grade 2 of 4, and I mentioned somewhere what staging system I use. And then the stage, I think on the H&E it looked better than the trichrome, but on the trichrome it's at least bridging. So this one I would get to a stage 2 or grade 2 of 4, stage 3 of 4, consistent with viral hepatitis B. That would be on my line. Anyone know what the second diagnosis is going to be on this one? The second line on this case, and I mentioned it while we were looking at it. So I would say something about the fat. And I make it a point because it's so common. Like half of viral hep C cases were fat. So fat is seen in a lot of other liver biopsies. In fact, a biopsy with fat might have something else going on 50% of the time. So I'd be aware. So I would put minimal steatosis for my second line diagnosis. And that would be how I'd sign this one out because I knew the labs. You could do, and I brought with me so you could see what the hep B surface antigen looks like if you want to do this stain. It works very nicely. So this is in the area that we looked at before, and you could see how obvious and how bright this is, how good the stain is. So if you need it, it's there. Most of the time, you're probably not going to need this, but if you do, it's there. So let's talk a little bit about viral versus autoimmune. And I want to show you another case of something that is a little different. And in this case, again, let's start with the pattern. So starting with the pattern, and this one looks a little more active, but overall, are you more based in the lobule or are you more based in the portal and periportal areas? Probably portal and periportal, right? Even though there is a little bit of inflammation in that lobule. And these can be hard. So this one is a case of chronic hepatitis pattern. So again, you've got your differential of chronic viral, chronic autoimmune are the main things in your differential. So we'll focus on that. But there's a lot of activity here. And there's even some necrosis and maybe some dropout in the central area. Maybe even some dropout here. Here too. So lots of inflammation. So this would be a moderate or severe activity. So this would probably be a chronic hepatitis with moderate to severe activity, a grade 3 or 4 of 4. And this one actually has some bridging fibrosis. But I wanted to focus on the grading of the activity. So something that's really active like this, with a lot of interface activity, even though there's no plasma cells, if you had a guess, more likely viral or autoimmune?
Autoimmune.
Yeah, so way more likely autoimmune. And you notice on this case, there's really not a predominance of plasma cells. But I would absolutely be thinking about that on this one. Now, this other case is also very active. And this one I'm struggling a little bit. Is this a lobular hepatitis, a chronic hepatitis, or is this an acute hepatitis? So let's look for a minute. It's kind of messy, but if I look here, there are some dead hepatocytes right at the butt of that arrow. There is some inflammation, but there's maybe a little bit more focused on the portal and periportal areas. And this one also, I don't know if you noticed as we were scanning around, has a fair number of plasma cells. So this did turn out to be a case of autoimmune hepatitis. However, I think the problem is now, how do we sign this out? Is this chronic hepatitis with severe activity, or is this an acute hepatitis? And I think people struggle with that. And kind of the term I use in cases like this, if I'm not quite sure, is I just say active hepatitis. The important thing is whether or not there's fibrosis. And this case did have extensive fibrosis. So it probably is an acute on chronic, which is the typical way that autoimmune hepatitis presents. And so I would say active hepatitis with bridging fibrosis with severe activity is what I say on this. And then in my note, I talk about consistent with autoimmune. So those are sometimes the ones I struggle the most with. Should I use acute or chronic? But just use the term active and then tell them how much fibrosis, because really that's going to be important to know rather than whether it's an acute pattern or a chronic pattern. But this is one of those in-betweeners that sometimes makes us struggle. But overall, I think this is more of a chronic pattern with the action focus on the portal and periportal areas. Now, one last slide to put up. This is another chronic hepatitis case, and there's not much inflammation. The only reason I'm showing this is I want to make sure everyone got that ground glass. So when you see it, it's going to jump out at you. And this one, almost every cell is ground glass. So almost every cell here, and sometimes that makes it harder when it's almost every cell, but see how homogeneous this looks? Unlike a typical liver cell, it's very homogeneous. So just kind of to get used to that look. So now I want to build a little, and I want to get a little more complicated. So everybody be thinking more than one thing can be going on at a time. And we're going to get to case 4. Case 4 is a 50-year-old obese man with a previous history of IV drug abuse. He presented to his primary care doctor with abdominal pain and malaise, and his transaminases were mildly elevated. So previous history of IV drug abuse, you're not only thinking of medications or drug abuse or alcohol, you're also maybe thinking about viral hepatitis, right, if you get IV drug abuse. So that's kind of in the back of your mind. And let's look at this, and everyone just kind of look as I scan around for a minute before anyone says too much. So overall, think about where's the action and what is it as we look at this case. So what's the main thing going on here? And maybe there's more than one main thing, but what are one of the main things going on here? So inflammation and fat are the two things that are coming to my mind. So let's start with one at a time. So the inflammation, portal and periportal, right? So maybe a chronic hepatitis pattern. So what's everybody thinking? Chronic hepatitis pattern, there's lots of lymphocytes. Don't see plasma cells, don't see a lot of mixed inflammation, saw a few EOs. So overall, it's a chronic hepatitis pattern, right? Definitely not acute. So chronic hepatitis may be viral, a little bit more activity than you typically see for viral, maybe moderate in this case. It is spilling beyond the interface in a lot of areas. Okay, what's the second thing going on here?
Steatosis.
Yeah, so steatosis, but more than steatosis, right?
Yeah.
So there's lots of fat. Now, everybody knows that, or everyone should be aware that some hepatitis C gives you a little bit of fat, but this is way too much. So you've got too much inflammation for this just to be fatty liver disease, and you've got too much fat for this just to be viral hep C with fat. So I think you have two processes going on here, and that's what most people miss. They get caught up in one and they say, this is just steatosis. But I think this is, if you see this much inflammation, no way. This is more than just steatosis. Okay, so we talked a little bit about the chronic hepatitis, and this actually turned out to be a chronic hepatitis C. So what I want to focus on a little bit on this case is the fatty liver disease. So the next few cases, we're going to focus on that aspect of this. So your top diagnosis, or one of your diagnoses, is going to be chronic hepatitis, maybe moderate activity. Remember, you take to grade the activity. It's what's going on at the interface and the lobule, and whatever is worse is what you do. It's not just what's sitting in the portal area when you're grading it. So I would say this is moderate, so probably a grade 3 or 4 activity. And with the trichrome, and we'll look at the trichrome in a minute, I think this one had about stage 2 or portal periportal fibrosis. And then we'd say consistent with viral hep C, because we find out the patient's laboratory values. That's what we thought it was. Then we find out his lab values. And my second line would be steatohepatitis, or non-alcoholic steatohepatitis. So let's talk a little bit about why it's steatohepatitis and not just steatosis, like in that last case. And let's just kind of look around, and not what are the primary things, but what are people seeing that tells them this is fatty liver disease? So we've got the macrovesicular steatosis. We've got large droplets, so the big droplets that push the nuclei to the side. We've got the little droplets, right? So that small droplet, macrovesicular. So now those are kind of newer terms. The droplets you could see are macrovesicular. If they're big and push the nucleus, it's large droplet. If they're smaller, it's small droplet. Microvesicular is for that fat you could almost not see, like in Rye syndrome. So you've got large and small droplet macrovesicular fat. You've got these glycogenated nuclei, right, that we talked about before, maybe in diabetes. And then we have more than just that. And I know it's hard because you've got your cells are damaged from the chronic hepatitis C too. So now it becomes hard how much of this inflammation in the lobule is due to the viral hepatitis, right? And maybe how much of these dead cells are due to the fatty liver disease. And that can be very hard. So what I try to find in these cases is some ballooning. So the ballooning of the hepatocytes is much more suggestive of something due to fatty liver disease. So now we're looking for balloon cells, and what's a balloon cell? So those can be tough because balloon cells can be confused with cells with fat in them. But balloon cells, can everyone see these guys? Right where my arrow is. That's a nice balloon cell. Now it's really easy if you can see, let's see if I could get it right there. So there's no fat in it. There's not great Mallory's. If you have really good Mallory's, that will help you. But we're not always lucky enough to see that. In fact, in NASH, non-alcoholic steatohepatitis, the Mallory is not so obvious, not so easy to see. So this is a ballooned hepatocyte. We have inflammation where we think some of it could be Hep C, but some of the sinusoidal stuff is probably from fatty liver disease. So what makes me diagnose this as steatohepatitis is the fat. Usually there's more than 5%. Many times it's way more than 5%. The ballooning with the damage of the hepatocytes. So those are right at the butt of my arrow. So those are the most important things, and the inflammation. So right above the arrowhead is that balloon cell, and there's inflammation around it. So that's what I need for a diagnosis of steatohepatitis. Ballooned, damaged hepatocytes, inflammation, and typically at least 5% steatosis. And it can be large or small droplet. That doesn't really matter. And do I stage and grade fatty liver disease? Well, I generally just describe what I'm seeing. My clinicians don't care if I stage and grade it. Here's some more balloon cells. But my clinicians just want me to say how much fat and how much damage. Because fatty liver disease, the type that progresses is the steatohepatitis, right? So fatty liver in general, like 30% of Americans have fatty liver. It's that steatohepatitis that progresses, maybe the 10% of people with that can progress to cirrhosis and hepatocellular cancer. So those are the ones we want to know about, and those are the ones your clinicians want to know about. So that's what's important in your diagnosis. Not that you use, and if you do use staging or grading, and most people use staging more than grading, if they use anything, Brunt's, staging and grading is what a lot of people use. There are others out there. I tend to just describe what I see. So extensive, steatosis with damage, ballooning, I'll just say it in words, and then how much fibrosis. So I think you can do whatever you and your clinicians agree to use. And like I said, most people who do grade and stage, staging to most people is a little more important, and they'll use Brunt's system. So as we look at this, what else are we seeing? So other things in fatty liver disease, the glycogenated nuclei, you could see fat granulomas. You could see Mallory's, which is not great in this case, so we won't look at it in this case. We'll look at it in another case. Anybody know how long does the fat stick around? So if you had somebody who lost weight, fat could stick around. That's pretty quick. That may just be weeks, but it's your Mallory's that can stick around for months. So be a little careful about that. And Mallory's is not specific, right, for fatty liver disease. Mallory-Dank bodies is what we call them these days. I'm going to put up the trichrome so we can look at that as we're talking. So Mallory-Dank, anybody know what that is? And why? Yeah. So it's, you could stain for that. It's the intermediate filaments, and you get degeneration of those filaments. So it's not just specific for fat. You could actually see it in biliary diseases, as we'll see later on this session. So it's just degeneration. And it's not seen as great in non-alcoholic steatohepatitis as in alcoholic hepatitis. Alcoholic steatohepatitis. And so your trichrome, and what you're looking for in your trichrome with steatohepatitis, and this one doesn't show it great, but we'll look at more later, is kind of a chicken wire pattern or a pericellular, perisinusoidal pattern, which, as you see on this case, it's not so great. This case is probably mainly due, or part of this, and you can't tell how much, is due to your chronic viral hepatitis. So you definitely have some portal with periportal fibrosis. That's why I had earlier said a stage 2 or 4. But let's wait until we get to a better case to look at the pericellular, periportal that really characterizes steatohepatitis. So let's wait until I've got some other cases I brought that show that better. So what I want to do is talk a little bit about concomitant diseases. This is really important with fatty liver disease. This is a case of somebody who clearly has two processes. And that's what you guys should be thinking of, or everyone should be thinking of as you're looking at this case. There is absolutely a portal and periportal process here, and there is absolutely fatty liver disease, right? And you don't want to just talk about one. There's too much, way too much inflammation for just fatty liver disease, way too much fat to be just a chronic viral hep C where you sometimes see a little bit of fat. Now this case is a little bit tricky. So what would be your differential for the periportal and portal inflammation in this case with these dense lymphoid aggregates? Hep C, and that's a great thought. But this case, I knew a little bit more about this patient when we got this case. This is a CLL patient. So don't forget about that. Patients with CLL can present in multiple areas, but it looks just like a pretty bad hep C, and typically it looks like lots of lymphoid aggregates, but there's not interface activity usually. It's very monotonous, but absolutely, and this one is all B cells if you ever checked. But yeah, I couldn't tell really the difference between this and a hep C if I didn't know history on this patient. The viral load was negative in this patient. That's correct, because that could happen too. You're absolutely right. You could have three things going on. Absolutely no question. In these days of immunocompromised patients, you could absolutely have three things going on. So I think this looks like a NASH case. I think we passed by some ballooning. There's some inflammation too. And this one has CLL. So again, two diagnoses. I make it a point whenever I have fat to have a second line diagnoses in my case include something about the fat. That's really important. And again, staging and grading not as important as saying what you see. Okay.
Do you find ubiquitin immunohistochemistry helpful?
So some people like to use that. I guess I feel like I could see it just as well on H&E. So some people do use ubiquitin. Some people use ubiquitin to look for Mallory's. Some people use cytokeratin 8 and 18 to look for ballooned hepatocytes. Anybody do that? So some people do that loss of cytokeratin 8 and 18. I don't find that very helpful. I think steatohep or ballooning can be very difficult. But you're looking for the cytoplasm has like filaments in it. Even if there's not Mallory's, it looks a little more filamentous. It can be very difficult though. Balloon cells don't always have to be bigger than the cells around it because some of them may be stuffed with fat. Okay, this is a patient who has autoimmune hepatitis. And this is something to keep in mind. So this patient, I was told, has autoimmune hepatitis, and her LFTs went up. And so this case came into me clinically as patient with autoimmune hepatitis, grade it for me. And I said, yeah, maybe there is, but it's not very active. But what do you really see here? Yeah, steatohepatitis. So now why do you think an autoimmune patient who was doing okay suddenly gets steatohepatitis? So they're on steroids. Yeah, so absolutely. So this is steatohepatitis from steroids. So, and this is in the middle, you can see some nice balloon cells right at the butt of my arrow. So don't forget about that. Sure, I can't tell if this is autoimmune hepatitis. If it is, it's not very active. If I did a trichrome and there was some portal fibrosis, this could be chronic hepatitis with minimal activity. But the key finding here is the steatohepatitis. And that is a key thing that your clinicians need help with. And that's why biopsies help. You know, my clinicians say, oh, we don't need biopsies anymore, right? We could do it all. We could do it on scans. But what they can't pick up is concomitant diseases, things that they're not even thinking about. And maybe staging, we can really be helpful. So I think there is absolutely still a need for liver biopsy, and we absolutely need to keep thinking about what can be other causes. and mixed etiologies in these cases. And this was one where the biopsy was vital. They absolutely would have missed what the cause of this was, and they would have kept treating maybe with more steroids without this one. Now I want to kind of put up a couple classic NASH. So classic NASH cases. And then what's your differential for NASH? So your fatty liver is the pattern we're seeing in these cases. And this is more of a little more pure pattern, although this one has a lot of inflammation too. So I keep that in the back of my mind. This may be a little too much to even mention something about this in your note. But what this case has nice fat, lots of it. It's got nice ballooning scattered about, maybe some apoptotic hepatocytes, but that really isn't usually seen. Apoptotic cells aren't usually seen as often as a ballooning with fatty liver disease. I still don't see good Mallory's, but I do see some ballooning. I think the arrow's on one cell that I think is probably ballooning, but can be really hard to tell ballooning again. But I think there is some here. There's inflammation, there's damage inflammation, and fat. So steatohep, this patient, let's just say I'm telling you, doesn't drink. So then this would be NASH. It could be what? Diabetes, obesity. What else? Some drugs can cause this. So lots of different things. What else?
Wilson's.
Yeah, that is a great thought. So Wilson's disease, I forget to keep saying that, just like drug, can cause any pattern. And one of the classic patterns with Wilson's is fatty liver disease with glycogenated nuclei. So that is classic. If this patient were at 40 or younger, I would do a copper stain, and I would also, if I was concerned, send it off for a quantitative copper. So copper stains not always give you the answer, cannot rule it out. So absolutely great thought. And then drugs. So absolutely, and then I would, again, I don't stage and grade it. Now, I like this one because look at all this small droplet stuff going on here. So these are so small, but they're not pushing it to the side. So this case has a combination of small and large droplet. Like I said, you could have both. And I guess I don't make a big deal out of that. I just say, extensive steatosis or large droplet steatosis with small and large droplet if you want to say that. I do mention this inflammation because this is concerning to me. This is too much. So I mention this and I raise the possibility of something else going on, and you should all do that. And then, if you know more history, you may be able to come up with more. I want to show one more NASH before we get into a little different pattern. So this one, way more fat, right? Lots of fat, a little bit of inflammation, and there's always going to be a little inflammation. Even from this power, I think I see some ballooning, but ballooning is hard for me in this case because of the fat. But maybe that cell, this not such a big one, but the one above that fatty droplet. Let's see if I could get it. That's kind of got the filamentous stuff kind of 2 cells above my arrow. But I think there's ballooning here, but this gets more challenging. The more fat you have, ballooning gets hard. What about that cell? You guys buy it for ballooning?
Yep.
Yes.
But it does get hard because sometimes you get small droplets that coalesce. But what about like maybe that cell? Maybe? But this one has a lot, and I would make it a point to say extensive, and see how this balloon cell, if I can get to it. See that balloon cell? That's smaller than the cells with fat, and that's why it can be so hard. But again, I don't find the immunohistochemical stains help me. So this looks like almost a cirrhotic liver. A lot of fibrosis, at least, with extensive fat. And so that's going to be important for you to describe. And what I wanted to show you is, in this case, I thought it had some nice, that chicken wire fibrosis, that's kind of classic for fatty liver disease, so this stuff. And if you look in the areas with the most ballooning, you'll see the most of this pericellular or perisinusoidal pattern of fat. So really good to recognize this pattern. And so when you're staging livers, it's a little different than staging them. When you stage them for chronic hepatitis, right, 1 is portal, 2 periportal, 3 bridging, 4 cirrhosis. In fatty liver, 1 is just this pattern, right? So you can sometimes have portal 2, but 1 can just have this. And then you get a little periportal in 2, and 3 you get bridging, and 4 cirrhosis. But 1 is different. So that's the kind of chicken wire pattern people look at. And do you need this for a diagnosis of steatohepatitis? No. So that's important. It helps me. You need the inflammation, the damage, and the fat. You don't need this. You typically do see it, though, in cases that have steatohepatitis. And again, I look in the areas with the most ballooning, and that's where it's really most prominent.
So when you have that much fibrosis, perisinusoidal, and you do not have ballooning, but you have fat, and you do not have inflammation, would that push you to consider steatohepatitis, the fact that it had some damage?
I would want to see, and that could be old damage. So that may be what you see like in a burned out cirrhotic liver. You might just see that fibrosis. So it may give you evidence of previous steatohepatitis. But if that's all I saw with fat, I wouldn't. Now, what I sometimes do, and I'm sure some of you use it too, the hedge statement of features of. Anybody use that? Features of steatohepatitis. If I'm struggling with what's a balloon cell, and am I sure, or if it's mixed with the chronic hep C and there's inflammation and damage and I'm not sure what it's from, I may say features of steatohep. But if I just see this pericellular, perisinusoidal, and I don't see active damage, degeneration, ballooning, it could indicate burned out disease. So I would want to see some degeneration, regeneration, ballooning, something. Usually, though, you see most of this in cases with a lot of ballooning, but absolutely, it's a clue when you have a cirrhotic liver and you see this. Now, this could also indicate some vascular abnormalities in those livers, too. So be a little careful. It's not entirely specific, but it does help you. Okay, so now I want to switch up a little bit, and we're going to stay on the fat pattern. And this is case...
Can I ask a question?
Sure.
You had 2 cases of hepatitis, and both of them with a lot of portal inflammation. And one case you said is CLL, another is you said you're going to mention the portal inflammation. So we see a lot of cases like that in daily practice. My question is there any specific histological features make us to need to risk the possibility or further evaluation for possibility of CLL? Because I don't want to make comments or think about CLL on every case.
Oh, sure. So the question is, if you see that dense lymphoid infiltrate like we did on that one case, when do you comment on that? I would not have even thought of that had I not known that patient had CLL. I would have really, there's not a great clue on that. That really looked like hep C to me. It could be a pretty inactive hep C where it's limited to the portal area. But I absolutely would not put comments to think about CLL. I think that's important. You don't want to worry your clinicians. I think it's unusual, and I only knew that in that patient. Now, what is important and what you do need to mention is when you see inflammation. And you just need to say there's more inflammation than is typical for fatty liver disease by itself. And in addition to thinking about the etiologies of fatty liver disease, diabetes, obesity, medications, you need to think about a cause of chronic hepatitis. So I absolutely, that case, I only got because I knew the history. So I would be careful about that, about mentioning that. I mean, if you know the history, then you could just do a B cell stain and they'll all be B cells. But I would not have mentioned that. That's a good point. I didn't want to mislead people to think about that.
Thank you so much.
Sure.
I have another question.
Sure.
About the, you mentioned there are some cases looks like active or acute hepatitis, but without a significant number of plasma cells. And in daily practice, we always struggling to differentiate the DILI or could be a autoimmune hepatitis, particularly for those cases do not have a lot of plasma cells. So is there any, what's your suggestion, this type of case or any other clue can leading us to one diagnosis other than the other one?
So in thinking about autoimmune versus viral versus other etiologies, plasma cells are a great clue, although as I mentioned, you could see plasma cells in acute Hep A and other things as well. Rosetting, so lots of cells around damaged liver cells and lots of activity. Multinucleation can be seen in autoimmune. So those are all things that would make me think about autoimmune, particularly severe activity. Hep C, lymphoid aggregates. Helps me. So that does help, but you're right, the labs are important, and that's why sometimes all we do is a descriptive diagnosis. Thank you. Okay, yeah.
Maybe a quick comment going back to the lymphoma. I have personally struggled with a couple of cases of Hep C that had more distinct lymphoid aggregates that were a bit monotonous, that happened to be external margins on lymphoma. This can sneak up on the person. They were extremely subtle, very distinct co-expression of protein CD43, and that's what we call.
Yeah, absolutely. Absolutely.
Another lymphoma that I kind of fear because it can be very subtle.
And leukemias too, although sometimes you'll see that in the sinusoids. So I've seen those show up in the sinusoids. So it's absolutely something that needs to be in the back of your mind, and you're right. Some of them are difficult to work up with stains. I entirely agree with you, and that is a pitfall for all of us. Okay, case 5. Case 5 is a 53-year-old man with normal BMI, a month of confusion, malaise, and jaundice. Laboratory values, his AST is a little higher than his ALT, but they're only minimally elevated. Alk Phos 318, total DILI 33, so pretty high. His ASMA is 1 to 80 and negative viral serologies. So as you look at this, everyone kind of think pattern. First thing we're going to think about is pattern. So where are we pattern-wise?
Alcohol levels.
Yeah, well, alcohol's good, but let's start with fatty liver pattern. So fatty liver pattern, but I think alcohol is a great thought. After we looked at all those cases of NASH, what's different besides the extensive fibrosis in this case? Let me get to a spot. So what's different about this? Lots of neutrophils. So satelitosis. So lots of neutrophils around balloon cells. And this isn't the best field. We'll get to a better one. But this just shows lots of neutrophils around balloon cells. And something else that, if I can get to a good field. What do you think? You could even see it from this power. So really ropey Mallory. So really good ropey thick Mallory. Here's some more. It's in the ballooned hepatocytes. It's clear. It's obvious. It's not like what we were seeing. Maybe down here. Maybe over here. Ropey Mallory with satellitosis. Very, very unusual to see that in NASH, right? So this is absolutely steatohepatitis. There's ballooning, there's damage, and look at that.
Is this more steatonecrosis?
I think some of this could be steatonecrosis. And that's another thing, alcohol can give you kind of a hyaline steatonecrosis. But look at that Mallory. You will never ever see that in NASH from obesity or diabetes. So on each side of that arrow, actually, if you follow the butt along, you'll find more Mallories. So satellitosis, great ropey Mallories. You may see vascular lesions. You may see, here's more, steatonecrosis. So this looks like alcoholic steatohepatitis. And if you think about what gives you alcoholic steatohepatitis, I think the rules are for men, it's more, I'm trying to think of it, it's more than 21 glasses a week. Women only get 14, so we can drink a little bit less. But that's kind of the definition when you're starting to think of is it alcohol or not. So this is a classic alcoholic steatohepatitis in this patient who had known alcohol. Now, if I don't know, I've been asked this before, what if the patient adamantly denies alcohol? Would I put alcoholic steatohepatitis on my line, and practically, how am I going to sign this one out? I would sign this out as steatohepatitis. with cirrhosis, C note. That's how I'd sign it out. And then I would give a differential, and I think some medications could do this too, but I think alcohol is a consideration. But I would not sign this out as alcoholic steatohepatitis with that history. I would just say steatohepatitis, give your differential, prominent Mallory's, and I think some medications are in your differential as well, but I would really heavily be thinking this is likely alcohol. I actually had a transplant patient once who was transplanted for alcoholic disease, and his post-transplant biopsy looked like this, and he swore he wasn't drinking again. But I think, you can only, get what you know from the history, and you can only say what you know from what you see on the slide. So this type of look is very suggestive of alcoholic steatohepatitis, and let me just show you the trichrome, and this trichrome has cirrhosis, which you could see. There's so much fibrosis, it's almost hard to see it, but it absolutely has the pericellular, perisinusoidal fibrosis as well, and it almost makes the whole thing look fibrotic.
Do you worry about saying regenerative nodules before you say cirrhosis? I mean, this certainly looks...
Yeah, this looks like it, but regenerative nodules can be tough to tell from cirrhosis, and that's something to think about. In a case where you've had necrosis, you can get regeneration in nodularity, but it won't be the whole liver. It should be. Usually, it's not total nodular transformation. It's usually only partial. But yes, that could be a concern. So, now, if this patient stopped drinking, what you may see is this. And you'll see that pericellular, perisinusoidal, you may see no more fat. You still probably will see Mallory's for quite a while, but that could be a clue. And a lot of the cirrhosis in the olden days that we used to say cirrhosis unknown etiology, if you look for this, that may help you. The only thing that a pitfall is vascular abnormalities can also give you this pericellular, perisinusoidal pattern, but it can at least give you a clue. So, and a few things about fatty liver disease. So, most common cause of elevated LFTs in the US, anybody know? Fatty liver disease. So it's really common. We used to see a lot of biliary and chronic viral hepatitis. I see fatty liver disease now every day. This is probably the most common thing most of us see in our practice. Some of these patients don't get biopsied, and again, the important thing when you're biopsying these patients is to rule out a concomitant disease, because that's important. Progression can be hastened. If a patient has hep C and fatty liver, they can progress faster. So that's important to consider both. A tricky thing, and something in this patient, is he had slightly elevated autoimmune markers. Don't jump to autoimmune disease. It's pretty common in fatty liver disease to have lowly elevated ANA or ASMA. So you may see that. So absolutely don't jump immediately to thinking about that, about autoimmune disease, unless you have other features. I wanted to show everyone another case that's in the differential of the fatty liver disease pattern. Let everybody look for a second. I don't see inflammation. I don't really see ballooning. It all looks pretty homogeneous. In the differential of kind of a smaller droplet fatty liver disease, anybody have any idea? Let me tell you about this patient. This patient has a diabetes, type 1, and their livers are out of control. Glycogenic hepatopathy, you guys hear of that? So glycogenic hepatopathy typically occurs in diabetes whose livers are out of control, and the case will come into you and they'll ask you about fatty liver disease. So that's what's going to throw you off. They're going to ask you, this is another case, same thing, just to get used to it. They're going to ask you about fatty liver disease, and you might even say, hey, is that a ground glass inclusion, right? But there's no halo, looks a little different. So, Possibly. I mean, in your differential is a really, a true microvesicular steatosis. Yeah, I think that is in your differential for this. So, do we have any stains that will help us? And I know this session is not many stains. I don't use many stains in medical liver, but you can do your PAS with and without diastase. So that's how you could tell what this is. I'm just going to show quick because it's pretty obvious. Lots of glycogen, normal liver cells always have lots of glycogen, but then when you digest it away, it's clearly not fat that was in these liver cells, it's glycogen. So glycogenic hepatopathy, again, it's in your differential, and it's in your differential because the patients come in, rule out fatty liver disease. Is that what's going on with my patient? So this is important to pick up in that differential.
What are their serologies look like?
Say that again?
Any specific serologies in those patients?
High sugar, really high sugar, and usually that's the story, out of control sugar. Okay, case 6. Case 6 is a 54-year-old woman with nausea, fatigue, and a history of atrial fibrillation. She presented to her doctor with a urinary tract infection. Her AST and ALT were a little elevated, ALK Phos 129, total DILI 4. Her viral serologies are negative, her BMI is normal, and she denies alcohol or drug abuse. And what you see when you look at this case, and this pattern is a little harder when I first grabbed this case. As I look around, there is a little bit of fat, not much inflammation, right?
Periportal Mallory.
Say that again?
Periportal Mallory.
Yeah, that's great. So he's immediately picking that up. That's a great pickup. Periportal Mallory, lots of Mallory. So a little bit of fat, lots of Mallory. Maybe the best Mallory, although that alcoholic case was great Mallory, but one of the best Mallory cases I've ever seen is in a patient with this. You guys see that? So, and you sometimes in these patients don't see much fat, but you see amazing Mallory. And the clue in this patient is the AFib. So the amiodarone, excellent. So there's lots of drugs that can cause fatty liver disease, but amiodarone is a classic. And the classic finding with amiodarone is abundant Mallory, not much fat. There classically is not much inflammation. You can sometimes see phospholipidosis. The only place I've ever seen that is in a book. But all the books say you could see it. It's pale staining around from the phospholipids and the lysosomes. I have a hard time finding that. I've seen several cases of amiodarone toxicity. So many patients on amiodarone develop elevated LFTs, but most do not develop actual disease. And the disease is complicated by the fact that these patients have heart disease. So they may have congestive hepatopathy and fibrosis from that as well. And see, look, this field almost reminds you of that alcoholic liver disease. And that's why I caution you against, if there's no alcohol, no history, patient denies it, be careful about labeling that patient, because some drugs can give you this fatty liver pattern. Anybody know other drugs that cause this? Tamoxifen? Steroids? Methotrexate classically, right? That causes fibrosis too, but it can also cause fat. So lots of drugs can cause fat, and I think that may be kind of a take-home message, right? Drugs can cause almost any pattern. Every pattern we've talked about. Drugs can even mimic autoimmune hepatitis with elevated autoimmune antibodies. So they can do almost anything. A website for everyone to write down if they don't know about this is livertox.nih.gov. It's amazing. You just put in the name of the drug and it'll tell you what that drug causes. I do that rather than books. It's quicker. PubMed is great too, though. So amiodarone, something to think about. Patients with a history of heart disease, a history of AFib. You see the fat, you don't see much inflammation, but the Mallory will jump out and bite you. And that's what happens on these cases. Usually my residents will say, look at all that Mallory. And that's the first thing. And then you say, but there's not that much fat. And there isn't another reason for the Mallory, like as we'll look at later in our biliary diseases, where you'll start to see reasons for the Mallory. You don't see that much here. So that is a good example of amiodarone. Again, the other drugs that cause fatty liver disease don't cause such prominent Mallory. So any questions on that case? And I just have the trichrome just to kind of show you. This one, there's so much. I can't even tell if this liver is cirrhotic or not, but I think it is. But sometimes it makes it hard because there's so much of the pericellular, perisinusoidal in these cases that it's like pure blue. But this patient was thought to be cirrhotic when they sent in this biopsy to us, and this was actually thought to be due to heart failure, all due to heart failure. But obviously, this biopsy was essential because we told them there was more than all heart failure here. And so again, that's why we all have jobs. We're still all very important, and there's lots of important things to see on a liver biopsy, even though there's lots of great tests available these days.
What would happen to that liver if they took her off the med?
It would get better. Would it get all the way better? I don't know. I mean, lots of cirrhotic livers can get better, right, these days. Okay, now this next case, this is case 7, and this is, let me just focus for a second so you can look while I'm talking. Okay, this is a 35-year-old woman who was admitted with fulminant liver failure and acidosis, encephalopathy, and coagulopathy, and this is actually from her pre-transplant liver. So all the other livers I showed you were just biopsies, percutaneous biopsies, or transvenous in patients, but this one we actually had the whole liver, and I think this liver has a couple patterns. So before we start thinking about what's causing this, let's think about our pattern. And I think because we just looked at fatty liver, I think there is some fat here. So I think let's just say that. And then the next thing going on here, what is this? Yeah, great. Extensive necrosis. And where is that necrosis? Yeah, so I think it's central, but I think it may be more than central. So this is probably a portal, so zone 1, but I think it's zone 2 and zone 3, so maybe submassive. So submassive necrosis, but it's more central than portal-based. And it's pretty consistently, if there are residual hepatocytes, they're periportal. And they have fat in them. Okay, so now we're starting to think, we've got a liver, it's got central lobular or zone 2 and 3 necrosis, it's got a little bit of fat. What about inflammation? As we're thinking about this case. Not much, right? So we've got a liver with necrosis, with fat. It's more central lobular. Here's some residual portal hepatocytes. So here's residual portal hepatocytes. And this is a 35-year-old who presented with encephalopathy. So what can give you central lobular necrosis? Let's just think about stuff. So drugs. What else? What about ischemia? What about if this patient died from something else, their heart stopped pumping, so low flow? What about Budd-Chiari? Someone's got, venous occlusions, maybe you'd see more congestion. Okay, so thinking about central lobular necrosis. So what did we say was the most common cause of fulminant liver failure? Yeah, in the United States. So acetaminophen. And acetaminophen classically presents like this. Classically presents with central lobular or submassive or massive necrosis, with fat, sometimes with hemorrhage or congestion, with very little inflammation.
How much Tylenol do you need to get this better?
So, what's interesting is this, a normal amount, maybe 1 to 5 or 7 grams in there. So Tylenol, maybe twice the maximum, can give you this, and if you're drinking and doing other stuff too. So I think it's around 14 grams, but I'm not sure of the exact number. And it can change depending on other things about you, particularly other drugs. And many people who take Tylenol with codeine and other stuff. And alcohol too has absolutely been shown to change that toxic level. So people don't do this, not everybody does this on purpose. It's probably just as likely to be not on purpose. Someone's got a headache after drinking a lot. They're trying to put off the, we all went out drinking, last night, and I'm going to take a bunch of Tylenol. That's not a good idea. I wouldn't take acetaminophen, take something else. But so it is kind of scary in that way that it's only about twice the maximal dose at times that can become toxic. So acetaminophen is one of those types of drug-induced liver injury that's kind of got a set dose that pretty much everybody gets it at that dose versus many other drugs like that Herbalife we looked at that are more due to your own intricate system, so more idiopathic, so it's different for everyone. Tylenol is a little bit more, we kind of know about it in trials, how much it takes to cause this. So this we absolutely knew was Tylenol. And so we didn't really have to think about the differential, but in some cases you will, because again, the patient may not even think, they just may think, hey, I had a backache, I had this, and they don't even think of that when you say, what did you take? Have you taken drugs or supplements? And they might not even mention Tylenol, because it's such a common thing to be taking. Now, I want to look at a couple other cases in the differential for this. So first, let's do one more Tylenol. So this one was a Tylenol one that is more central-lobular rather than almost submassive. So this one was almost a little easier in a way. Anybody know what else could cause this central-lobular pattern? Anyone seen mushroom poisoning? Amanita? That can cause this central-lobular necrosis. But what you should notice about this Tylenol case, similar to the other, see here there's some hemorrhage. Necrosis central, there's fat too. So there's fat too in this case, and there's not much inflammation. So central lobular, not much inflammation, hemorrhage, fat, that's kind of all classic. And your portal area looks okay, just lots of fat for Tylenol. Okay, something else. Cocaine. Cocaine can cause necrosis and a lot of other drugs as well, good thought. Okay, what about this one? This one kind of looks similar.
Congestion.
Yeah, congestion. And it's central lobular. So yeah, this could be Budd-Chiari. This could be some other type of congestive hepatopathy. But I'm going to try to get you guys to the clue on this one. So something is causing a vascular problem with central lobular necrosis. And I'm showing you guys this artery. Yeah, great, amyloid. So amyloid can absolutely cause this, and this was an amazing case that I saw. And look at, the funny changes in the vessels were the clue to what it was to identify amyloid, but the pattern is central lobular. So not all central lobular necrosis is drug or mushroom. I think that's important to remember. Other vascular etiologies can do this, and this is something we commonly see in autopsy livers. Now, what about other patterns? So we're in the necrosis pattern now. So in this necrosis pattern, think about what else. So we've already talked about the differential for central lobular necrosis. This is more of a non-zonal necrosis. And I'm just going to scan it a little bit so you could get a feel. It's kind of, there's fat in this one too, but remember, fatty liver is so common that it may not be helpful for the etiology. But so you've got, it's central here, but then there's all this other necrosis that's not really central.
It's very viral.
Viral's great, and herpes is a great thought. So this is, we call this geographic or non-zonal necrosis. There's also not much inflammation in this case. So the differential for this pattern, the best one is, as mentioned, viral, and herpes is one of the viruses that causes this. This is absolutely, this is from an autopsy case, but I have seen this on a biopsy before. Don't wait for your stains, call your clinicians. Now, somebody mentioned herpes. Herpes is in your differential, but what else is in your differential? Absolutely, excellent. So adenovirus gives you these huge nuclear inclusions. So adenovirus can do this too. So you get your pattern. This is necrosis. It's not central. It's kind of zonal. It's kind of all over the place. There's, again, not much inflammation. So it's probably not a severe viral or autoimmune hepatitis causing this, because those would give you necrosis with lots of inflammation. And then you start to go to a higher power and you're looking for inclusions. And these are huge nuclear inclusions, not really multinucleated ground glass, classic for herpes. And you're going to do your stains, but you're absolutely going to call your clinician. Your patient may not make it. These are classically an immunocompromised. I think that was a T-cell lymphoma patient, but they're usually HIV, they're cancer patients. And this, someone mentioned herpes, so I wanted to show you herpes. Same thing when you look at it, and this one does have a little inflammation, but as you look at this is portal necrosis. That's maybe a little more portal, but it goes from portal area to portal area, so maybe a little bridging, kind of no good. That's more central, so it's kind of all over. And this has more of the classic herpes inclusions. So again, you call your clinician and you do your stains. Even if you're not sure, you call your clinicians and you do the stains. So this is something that we all need to be aware of. We need to worry about when we see necrosis. Not always a classic ground glass multinucleation. So herpes can also give you this pattern. Now, this is an HIV patient, and this is getting back to you could have more than one thing going on at once. And this has that necrosis pattern, no question. So everyone's thinking herpes, because it's an immunocompromised patient with these nice herpes inclusions. These are a little better for herpes that everyone's a little more used to with multinucleation. A little better. But you keep looking, right? Because livers can have more than one thing, particularly in immunocompromised patients, and this patient had this too. So granuloma, what's your differential for granuloma? Sarcoid, infectious, primary biliary cholangitis, right? So this patient had MAI also. So don't forget, livers absolutely can have more than one thing going on. And the last infectious one I wanted to show you in this differential, this was a HIV patient, and it looks like this is kind of what you'd see in herpes or adenovirus. This necrosis all over the patient place, but these were actually poorly formed granulomas. Here you could see a little bit of the multinucleated giant cell. So this was disseminated TB in an HIV patient. So this, even though that's supposed to be granulomas, this patient just didn't have a lot of inflammation, and mainly what we saw was the necrosis in the granulomas. So don't forget about this, even though technically this should be in your granuloma differential. Since this is mainly necrosis and not well-formed granulomas, this is going to have to be in your submassive massive necrosis pattern.
Do you see bugs on the TB stain?
So if you did a TB stain, absolutely, and we did. And they were all over, not like the TB that all of us struggle and have to go to super high power and spend for, these were jumping out at you. And this case, the last one in the vascular, or the last one in the massive necrosis one, and this is less common, so I saved it for the end. But on this biopsy, so everyone knows the pattern here is necrosis. And it looks like it's central, because here's a portal area. So it's central necrosis, your portal area's got some liver cells intact, definitely necrosis, a little bit of inflammation, but not a lot. So I'd be thinking vascular, right? Tylenol could do it too, but this was a patient who actually had a vascular obstruction and a Budd-Chiari type patient, but you could see how you could mix this up with Tylenol with the fat and the central necrosis. So you are going to have to find out some type of a history, and I don't see any amyloid, any thickened blood vessel, but this was Budd-Chiari, and this is what it can look like. So remember to keep that in your differential. And with that, I think I'm going to close the Facebook Live portion of this, and then we're going to go on and do the last 2 cases. So I thank everyone on Facebook for joining all of us. Thank you. Okay, so now we